Hello guys, today I'm going to discuss plasma cell neoplasm. So I will discuss half of the condition today and others I will discuss other day. So plasma cell neoplasm comes under B cell lymphoid proliferations and lymphomas. So there are plasma cell neoplasm, plasmacytoma, plasma cell myeloma, plasma cell neoplasm with associated paraneoplastic syndrome. So, what is multiple myeloma? Multiple myeloma, also known as plasma cell myeloma, it is a bone marrow based neoplastic proliferation of the plasma cells. So, multiple myeloma is defined by combination of plasma cell myeloma, usually associated with a serum and or urine monoclonal immunoglobulin, either evidence of organ damage related to disease, or in the absence of organ damage, laboratory or imaging finding that are suggestive of high risk of developing end organ damage within 2 years. Let me switch on the pointer. Okay. So, what are the types of multiple myeloma? Multiple myeloma can be smoldering or asymptomatic myeloma. It can be light chain myeloma, oligosecretory, non-secretory, or plasma cell leukemia. Firstly, I will discuss smoldering or asymptomatic myeloma. So, both criteria must be met. First is serum monoclonal protein, that IgG or IgA, more than equal to 3 gram per deciliter, or urine monoclonal protein more than equal to 500 mg per 24 hour, and or clonal plasma cells 10 to 60%, on there is absence of myeloma defining events or amyloidosis. So both must be met. Smoldering multiple myeloma is present approximately 0.5% of the population above the age of 40 years, and it progressed to multiple myeloma at a rate of approximately 10% per year over first 5 years following diagnosis, and 3% per year over next 5 years, and 1.5 year per year thereafter. So this is the criteria for the smoldering myeloma, and this is the progression of the smoldering myeloma to the multiple myeloma year wise. So these are the fact about the multiple myeloma. The median in India, the median age is 59 years. It is a 14th most common cancer. It is 2 to 4 fold higher in the first degree relative in the with the multiple myeloma, but in US the median age is 69 year. It is more common in males and almost always preceded by the MGUS, and more common in blacks as compared to white population. So, what are the lifestyle and the occupational factors which increase the risk of the myeloma? First one is obese individuals have higher level of cytokines such as interleukin 1, insulin like growth factor 1, which are also produced by the adipocytes, and that are the potent growth factors for the multiple myeloma cells. So the obese individuals are at higher risk. Second is people exposed to the fresh wood dust and working in sawmill factories were reported to have increased risk of myeloma in some of the studies. And the third one is autoimmune diseases, especially rheumatoid arthritis, pernicious anemia, and chronic viral infections such as HIV, hepatitis C has been proposed as a risk factor of myeloma. So these are the lifestyle and occupational factor which are associated with the myeloma. So this is the pathogenesis of multiple myeloma. The cell of origin for the myeloma is the post-germinal center B cells that are committed to terminate differentiation into the long-lived marrow plasma cells. So in normal individual, there is progression to the monoclonal gammopathy of undetermined significance. Then from MGS, there is conversion to the multiple myeloma, and there are overexpression of the oncogenes. These are the oncogene overexpression of these genes, and these are the cytogenetic abnormalities like immunoglobulin heavy chain translocation and 11q32 in 50% of cases of the MGS, and there is hyperdiploidy. So these are the progression driver mutations like genetic lesions, bone marrow microenvironment, which also contribute for the myeloma. The RAS mutations, secondary translocations, mixed abnormalities, there is increased angiogenesis, there are different pathways, and finally there is end organ damage which usually occur within the 2 years. Like which are end organ damage is characterized by the lytic bony lesions, hypercalcemia, renal dysfunction, and anemia. So this is another slide which shows the pathogenesis of the multiple myeloma. And these are the genomic abbreviation which is included into the MGS, plasma cell leukemia, and the myeloma. Like hyperdiploidy, translocation 1114, translocation 414. There is cyclin D dysregulations, RAS mutations, IGH MYC rearrangements, and TP53 inactivation, etc. So this is the slide showing the interaction of the myeloma cells with the bone marrow stroma cells. Both myeloma cells and the bone marrow cells interact and release cytokines which favors myeloma cell survival, and these are the pathways. These are the pathways that constitutively activate in the myeloma cells, and then these secrete the cytokines, anti-apoptotic proteins, cell cycle modulators, and protein involved in migration, invasion, and autophagy. Nuclear factor kappa B activated in both bone marrow stromal cells and myeloma for regulation of the VCAM1, VLA1 adhesion, and there is a release of this VGF and HGF from the myeloma cells. And this is the mechanism of the bone remodeling in the multiple myeloma. This is shown mechanism of the bone remodeling in the multiple myeloma. So the major factors affecting the osteoclast and the osteoblast activation, thus balance between the bone formation and the bone reabsorption, the receptor activation of the nuclear factor kappa B receptor, and the receptor activation of the nuclear factor kappa B ligand. And there is macrophage inflammatory protein 1 alpha stimulate the osteoclastogenesis and osteoclast activity, while the osteoporogenin act as a decoy receptor for the rank ligand, reducing its action. So these are the factors like nuclear factor kappa B ligand, macrophage inflammatory protein 1 alpha that stimulate the osteoclastogenesis and osteoclast activity. And then there is DKOF1, DKK1 inhibitor of the osteoblast activity. So there is activation of the osteoclastogenesis, there is activation of the osteoclast activity, and there is inhibition of the osteoblastic activity. So in the presence of the myeloma cells in the bone, the normal balance between the osteoblast, osteoblast and osteoclast, there is normal balance or is totally inverted. So myeloma cells, they have written कि myeloma cells specifically secrete factors to promote the osteoclast activation, and there is upregulation the rank ligand MIP1 alpha and to inhibit the osteoblast. So in multiple myeloma, the myeloma cells also secrete the factor which promote the activity of the osteoclast, but that decrease or inhibit the activity of the osteoblast. So you have seen the myeloma patients have very fragile bones, and they can present with the unexplained pathological fractures. So this is the summary of the clinical manifestation in the myeloma. There can be renal failure, there is increase in the monoclonal protein, there can be hyperviscosity, amyloidosis, light chain deposition disease, and there can be infections. A patient can present with bony pain, hypercalcemia, anemia. Why there is anemia? Because there can be anemia can be due to the renal involvement and can be due to the marrow infiltration. So this is the revised criteria for the diagnosis of the multiple myeloma. So they have mentioned both criteria must be met. First one is clonal marrow plasma cell more than equal to 10% or biopsy proven bony or extramedullary plasmacytoma. First one is this, either this or this, and any one of or more of the following myeloma defining events. Evidence of end organ damage that can be attributed to the underlying plasma cell proliferative disorder, specifically can be hypercalcemia, that is serum calcium more than 0.25 millimole per liter or more than 1 mg per deciliter or higher than the upper limit of the normal, that is more than 11 mg per deciliter. Renal insufficiency, the creatinine clearance is more than 2 mg per deciliter. Creatinine clearance is less than 40 ml per minute, and serum creatinine level is serum creatinine level is more than 2 mg per deciliter. Anemia, hemoglobin less than 10 gram per deciliter or more than 2 gram per deciliter below the lower limit of for the normal age and gender. And bony lesion, one or more osteolytic. There are osteolytic lesion on the skeletal radiography, that is CT or PET-CT. So, according to the revised diagnostic criteria, both criteria must be done. First one, this clonal bone marrow plasma cells more than equal to 10%, or there can be biopsy proven bony or extramedullary plasmacytoma. Either this plus one or more of the following. This is the CRAB criteria. So plus one or more from the CRAB criteria. The presence of the biomarkers associated with near inevitable progression to the end organ damage, often we call either acronym SLIM. So we now use SLIM criteria because criteria provides us more pre earlier information about before that end organ damage, because we want to treat the patient, or we want to treat the patient before the any severe end organ damage occurs. So we use now the SLIM criteria. The S for the 60, that is close. So one or more of following should be present. S for the 60, clonal bone marrow plasma cell more than equal to 60%, or Li for the light chain ratio, that is involved upon uninvolved serum free light chain ratio more than equal to 100, and M for the MRI, more than one focal lesion on the MRI study, at least 5 mm in size. So the SLIM criteria is good as compared to the crime criteria, because in this criteria we can predict the multiple myeloma before the end organ damage. We can pick up it early. We can treat, and there are so many treatments are available now. So with this criteria, we can pick the patient early. So why SLIM were added to the CRAP criteria? So biomarkers are used when a patient had 10% or more monoclonal plasma cells from the bone marrow biopsy, but there is no clear organ damage, and also meet at least one of the SLIM biomarker criteria. As I earlier explained, the SLIM biomarker criteria. So before the SLIM CRAB criteria, the patient who met the SMM smoldering multiple myeloma definition were often not treated until they developed the organ related symptoms of CRAB criteria. So SLIM criteria was introduced in 2014 by the International Myeloma Working Group, because these markers indicates a high risk of progression to the symptomatic myeloma within the short period, about 2 years. So they added the SLIM markers to the CRAB criteria so that we can detect that these patients can progress to the high risk multiple myeloma. We can start, we can identify the patient who need to start treatment sooner. So we can see the clonal bone marrow for the multiple myeloma, clonal bone marrow plasma cell more than equal to 10%, or biopsy proven bony or extramedullary plasmacytoma, and one or more of the following myeloma defining events, that is CRAB criteria, as I earlier explained, plus or it can be clonal or bone marrow plasma cell more than equal to 60%, or there can be involved or uninvolved serum free light chain ratio more than equal to 100, or more than one focal lesion more than equal to 5 mm in size on MRI study. So I will discuss the clinical features in the next video. Thank you.